Good afternoon, and thank you very much for inviting me to speak at this year's Bangkok Symposium. It's always a pleasure to be with all of you, even though virtually, for the Bangkok Symposium. And thank you for asking me to speak and share my thoughts on HIV infection in the next decade. Of course, we all know the remarkable successes of HIV treatment and prevention that has seen a marked change in the HIV and AIDS landscape globally. Nevertheless, in our region, in the Asia and the Pacific, much work needs to be done in the next decade to catch up and to really achieve the 1990 goals that have been set globally. As you can see from this graph, we are a little behind in each of the treatment cascades, and there is much work. Take, for instance, the first 90 HIV testing. Again, recent data shows that in Asia and the Pacific, key populations are most at risk for new HIV infections. However, HIV testing, which is the entry point for prevention and treatment, remains low and averages about half in each of the key populations. And about half of key populations in our region do not know their HIV status. Therefore, it is not surprising that late diagnosis in Asia and the Pacific remains the norm rather than an exception. So, what can we do to address these shortcomings in our region? We have, as you know, plenty of science and plenty of evidence which leaves us to accelerate the uptake of this evidence to improve our HIV treatment cascade and as well as prevention intervention. Let's first of all look at how we can improve the first 90, namely HIV testing. This paper looks at the effects of HIV self-testing compared to standard HIV testing in the general population, with evidence from 14 randomized controlled trials, and showed that basically HIV self-testing doubles the uptake of testing in the general population. It was also associated with achieving high HIV positivity and linkage rates, and importantly, was not associated with increase in self-harm or suicide as has been feared initially. The WHO has included HIV self-testing in their recent guidelines published in July of 2021. In addition to expanding HIV self-testing, the other important initiative in the next decade will have to be shifting current management of patients living with HIV or people living with HIV from a hospital or clinic-based setting to community-based setting where appropriate. This systematic review shows that decentralized and mobile testing strategies were successful in reaching younger and hard-to-reach populations. The use of community healthcare workers, whether they're peers or lay workers, and directly observed therapy showed positive effects across the three treatment cascade targets, especially in lower and middle income countries. Same-day HIV testing and antiretroviral therapy initiation was also shown to improve retention in care and subsequent virologic suppression within these community-based models, and deployment of community health workers, peer and peer workers also significantly improved viral suppression. Task shifting to home visits improved adherence, and finally, the use of technology and digital intervention increased the interventions and supplemented the second and third 90 in the treatment cascade. So, more investment in community-based HIV initiative in lower and upper and middle income country is needed given the success in many different models, in particular in sub-Saharan Africa, but also, of course, here in Thailand, where key population-led health services, including this one from involving transgender people, have been shown to be successful. Another successful model from the Thai Red Cross Anonymous Clinic in Bangkok showed that same-day antiretroviral therapy initiation is possible and is associated with good retention in care, which was just recently published by Dr. Nitaya in the journal of in the JIS journal. And finally, the next decade will surely see an increase in the use of digital technology in all aspects of HIV treatment and prevention initiatives, from enhancing prevention messaging to promotion of HIV self-testing. Instagram, Twitter, and Snapchat have been shown to work well, although Facebook has been less successful. Other successful results have been seen in increasing PrEP uptake through education using digital technology and through increased motivation to use and linkages to PrEP services through digital technology. Refinement of big data algorithms for surveillance is another important use of digital technology, as is linkage to care, adherence to medication, and gamification to improve adherence. So I think just as COVID-19 has accelerated the use of digital technology in all aspects of medicine, certainly in the next decade of HIV treatment and prevention, we must do more to ensure that digital technology, particularly in a highly stigmatized environment that we live in, can play a major role in increasing awareness, in improving HIV testing and linkages to care, as well as adherence to both PrEP and treatment. Moving on to antiretroviral treatment and prevention, I would like to spend a little bit of time in discussing new paradigms in HIV treatment. Firstly, of course, simplification of both naive as well as maintenance regime in the form of two-drug regime. The use of a combination of 3TC and dolutegravir has now been included in both the EACS guidelines as well as the DHHS US guidelines as of last year. It has not, till now, been included in the WHO guidelines. Studies, particularly the landmark Gemini study, shows that initial two-drug regime showed no difference in biological suppression and no differential impact of low adherence for two-drug regime versus a three-drug regime. In switch studies, namely Tango and SWORD, as well as SALSA study, which was discussed at the July IAS 2021, once again, there was no major differences in the virologic outcomes when switching from three-drug antiretroviral regime to the combination of dolutegravir and 3TC in those who are virally suppressed. Another advancement in antiretroviral treatment and prevention, of course, the excitement around a new formulation, namely the long-acting injectables, of which there are now several coming into the market or at late phase of clinical trials. And here I summarize the different clinical trials for both treatment as well as prevention, utilizing long-acting injectables, including cabotegravir and lenacapavir for treatment and cabotegravir for prevention. what switch, for instance, of long-acting cabotegravir in combination with rilpivirine shows that there is non-inferiority, i.e. maintenance of virological suppression, that was demonstrated in those who were switched to a combination of long-acting cabotegravir and rilpivirine. Nevertheless, much more research needs to be done in terms of the use of long-acting injectables, feasibility and acceptance, particularly in our setting here, given that many patients are comfortable with single dose, single pill combination therapy that's been widely available for many years. The role of long-acting cabotegravir, which has recently been approved by the FDA, also warrants further implementation research in its role in PrEP in different key populations. And certainly I think this has the potential to be a game changer for PrEP in our region and globally. As we all know, much work needs to be done with PrEP that is now 10 years old in terms of the confirmation of the success of PrEP in several landmark studies in New South Wales, in Australia, where a PrEP scale-up has been taking place in the last 5 years, has recently shown a remarkable decline in new HIV diagnoses in both Australian-born as well as overseas-born men who have sex with men. The impact has been higher in Australian-born men, and overall there was a remarkable decline in new HIV diagnoses in MSM in New South Wales, where, as you all know, the incidence of HIV has already been at very low levels in the last many years, thanks to scale-up of antiretroviral treatment, in particular in Australia. As mentioned earlier, despite 10 years of having very good evidence of the effectiveness of PrEP in different settings with large landmark clinical trials, the adoption of PrEP as a national policy and program has been somewhat slow, although thankfully we are starting to see an increase in across the world region, as you can see in this bar graph here. Again, Thailand leads the way with scale-up of PrEP in countries in ASEAN, with this Princess PrEP project that utilizes same-day PrEP and key population-led services that have shown to be effective in scaling up PrEP in Thailand. And several programs are now underway to expand this PrEP program nationally. What can we learn from the PrEP scale-up in Australia? What has been successful, and how can we improve PrEP scale-up in the next decade in our region and globally? Of course, local factors such as high-level political support with clear targets for reducing HIV have been sort of the plan in Australia for a long while. Australia is also blessed with a very functional primary care system, and surprisingly, they were able to get generic PrEP at relatively low cost. And I think one of the key success factors in Australia is, of course, the very HIV literate, mobilized, and pragmatic gay community that have been active since the beginning of the HIV epidemic in Australia. With these factors, it is not surprising that PrEP has been successful in its rollout in Australia, that many elements need to be emulated across the region. Of course, in countries where MSM is highly stigmatized, this may not be as easily implemented as it has been in Australia. To a large extent, stigma and discrimination has also been a major factor in the lack of adoption of a highly effective HIV prevention program amongst people who inject drugs, and that's methadone or opioid agonist treatment, as well as needle syringe program, for which there are still many countries around the world where these evidence-based prevention programs have not been adopted to scale. So the next decade also means that we not only scale up and accelerate adoption of new tools such as PrEP and long-acting injectables, and scale up further antiretroviral therapy and innovative testing measures, but also old tools such as harm reduction. Moving on to management of people living with HIV, the success of antiretroviral therapy means that we have people aging with HIV, and unfortunately this has been shown to be associated with multiple comorbidities, which adds to the complexity of managing our patients living with HIV. And these comorbidities include cardiovascular disease, metabolic disorders, cancers, and mental health issues. What is important in the next decade is for us all to provide a person-centered approach to clinical care that not only looks at achieving and maintaining viral suppression, but also making sure that we pay attention to the multiple morbidities that our patients are at risk from, and to intervene in modifiable risk factors such as host and lifestyle risk factors, ART-related side effects, and also paying attention to access to care. As you all know, inequities and inequalities are major. In July of last year, several of us were involved in a consensus statement that was published in Nature Communications that called for an expansion of our services to patients living with HIV beyond the attention that's put into HIV viral load suppression, with patients living with HIV living a longer, healthier life. We drew attention to health systems in terms of providing patient-centered care that also looks at issues with aging with HIV, frailty, and call upon integration of care that includes management of non-communicable diseases, substance use, mental health, in addition to HIV treatment. And of course, stigma and discrimination, which still, unfortunately, remain a problem in many healthcare settings, must also be addressed. Lastly, despite the advances that we've seen in HIV treatment, prevention, and models of delivery of care that I have attempted to summarize just then, there are, of course, many gaps that remain in our scientific knowledge and in our armamentarium to bring an end to AIDS. First of which is, of course, we still need an HIV cure. And it's a little disheartening to see that the investment in HIV cure research has plateaued in the last 3 years, and we must do more to advocate for larger investment in HIV cure research as also in investment in HIV vaccine. As we've all borne witness to in the last 2 years, hefty investment in COVID-19 research has led to remarkable development and, of course, delivery of COVID-19 vaccine to billions of people around the world that has brought a turnaround in the COVID-19 pandemic. Although there's still some way to go, nonetheless, the ability to develop the vaccines and deploy them in less than a year has been nothing short of a modern medical miracle, but that was only able to be achieved through amazing scientific collaboration internationally, investment from biotech companies and pharmaceuticals, and investment from governments, as well as philanthropy that have brought us to where we are with COVID-19 vaccines. So there is much to be learned from us in the HIV world, from the acceleration of COVID-19 research, that we can adapt to our own ongoing research, so that the last few miles that we aim to cover in order to end AIDS will become possible, whether it's in a cure for HIV or in HIV vaccine research. Of course, in addition to biomedical science, research and implementation of what we already have, the Achilles heel of the HIV response that we must continue to work on is that of stigma that remains rife in our region, as this chart from UNAIDS shows. And as we know, overcoming stigma is not easy. We've been trying to do that for the last 4 decades, but research in stigma now tells us that there's no one size that fits all, and to be able to effectively overcome stigma, whether it's stigma towards people living with HIV or intersectional stigma towards people who use drugs or MSM or sex workers, the key thing is to have a program that's longitudinal. We know that single session interventions don't lead to lasting change, that stigma interventions need to be multi-level and in order to be sustained. And of course, it also has to have a multi-component model to be effective. And finally, what we know also drives stigma is, of course, the multiple policies and laws that continue to exist that impede our HIV response, laws that criminalize sex work, that criminalize drug use, as well as same-sex relations remain in many countries in our region. And the concern is, of course, a growing conservative political environment will not make it easy for us to advocate and to effect change in these laws.